Good evening, Dr. Phil here. Today we'll be discussing on COX enzyme inhibitors Part 2, Adverse Effects of Nsaids. Gastrointestinal side effects. The most common adverse effect of Nsaids are GI-related, ranging from dyspepsia to bleeding. Gastric mucosa damage is present in around 20% of chronic NSAID users. Prostaglandins PGI2, PGE2 decrease gastric acid secretion. PGE2 and PGF2 alpha increase gastric mucus production. PGD2, PGE2 and PGI2 improve the microcirculatory blood flow of the gastric mucosa. Nsaids that inhibit gastric COX-1 reduce the beneficial levels of these prostaglandins, resulting in increased gastric acid secretion, diminished mucus protection, increased risk for GI bleeding and ulceration. Some Nsaids such as aspirin can irritate the gastric mucosa directly. Damage to small intestines can occur due to Nsaids, but it is unclear if it occurs via a COX-dependent mechanism. Clinical features. The patient may be asymptomatic. There may be dyspepsia and nausea from gastric mucosal damage. GI bleeding from gastric ulceration may occur. Gastric perforation and septic shock can occur. To reduce the risk of GI bleeding and ulceration caused by Nsaids, avoid Nsaids in patients with or are at risk of GI bleeding and ulceration. Avoid Nsaids with a higher relative selectivity for COX-1, i.e. use COX-2 selective Nsaids. Prescribe misoprostol or proton pump inhibitors along with Nsaids. Use the lowest effective dose and for the shortest duration possible when Nsaids are used. Nsaids should be taken with food or fluids to diminish GI upset. Renal adverse effects. COX-1 and COX-2 are constitutively expressed in the kidneys and are responsible for the production of renal prostaglandins. Two prostaglandins are important in renal function: PGE2, which enables water reabsorption and mediates compensatory vasodilation to offset the action of noradrenaline or angiotensin II. PGI2, which maintains renal vasodilation and blood flow under circumstances of physiological stress such as hypovolemia. Nsaids reduces the production of PGE2 and PGI2, resulting in hypertension, fluid retention and edema. Patients with a history of heart failure and kidney disease are at particularly high risk. The beneficial effect of antihypertensive medications can thus be mitigated by Nsaids. Compromised renal blood flow, especially in patients who are neonates or elderly, have heart, liver, or kidney disease, or have reduced circulating blood volume. Nsaids can cause irreversible analgesic nephropathy with chronic use. This is characterized by chronic nephritis with renal papillary necrosis. Respiratory side effects. Bronchoconstriction can be triggered by Nsaids in about 10% of patients with bronchial asthma. This occurs as Nsaids inhibit PGE2-mediated bronchodilation by reducing PGE2 production from COX inhibition. Nsaids inhibit the synthesis of prostaglandins but not of leukotrienes, which are potent spasmogens. Inhibition of prostaglandin synthesis can cause a shift towards leukotriene production and therefore increase the risk of bronchospasms. Cardiovascular risk. COX enzymes may have a cardioprotective function by maintaining coronary blood flow via prostaglandin production. For example, endothelial COX-1 releases PGI2 to mediate vasodilation and inhibition of platelet aggregation. Vascular smooth muscle COX-2 releases PGI2 and PGE2 to mediate vascular smooth muscle relaxation. Studies have shown that Nsaids can increase the risk of coronary thrombosis, and this may be due to reduction of prostaglandin synthesis by Nsaids. The VIGOR trial showed an unexplained increase in the incidence of myocardial infarction in the COX-2 group in comparison with the non-selective group. Rofecoxib was thus withdrawn in 2004. In 2010, the Medicines and Healthcare Products Regulatory Agency in the UK concluded that the use of COX-2 specific inhibitors increases the thrombotic risk from 8 to 11 events per 1,000 patient years. Following a review in 2013 by the European Medicines Agency's Pharmacovigilance Risk Assessment Committee, diclofenac has been implicated in causing a similarly small increase in risk of arterial thrombosis. Theories of mechanisms whereby Nsaids cause adverse cardiovascular events. Via inhibition of vascular COX-1 and COX-2. Inhibition of prostacyclin, which is a vasodilator produced by COX enzymes in vessels, causes hypertension and thus adverse cardiovascular events. Another mechanism is inhibition of renal COX-2. This causes hypertension as renal COX-2 at the macula densa regulates renin release and hence blood pressure. As renal COX-2 controls the methylarginine system that suppresses the release of cardiotoxic asymmetrical dimethylarginate ADMA by the constitutive nitric oxide synthase enzyme, inhibition of renal COX-2 results in increased ADMA and adverse cardiovascular events. To reduce the risk of adverse cardiovascular events, Nsaids except for aspirin should be avoided in patients who have pre-existing risk factors for cardiac and thromboembolic events. It is recommended that Nsaids should be used in the lowest dose for the shortest time possible. For patients with cardiovascular disease in whom Nsaid treatment cannot be avoided, naproxen appears to be the least harmful. Regarding aspirin, an increased risk for cardiovascular events such as myocardial infarction and stroke has been associated with all Nsaids except aspirin. Aspirin has gained much more usage at lower doses for the prevention of cardiovascular events, such as stroke and MI. Aspirin has a very high degree of COX-1 selectivity, and this may confer to aspirin's cardiovascular protective effect, thought to be due to a reduction in the production of thromboxane A2. Nsaids with a higher relative COX-2 selectivity have been associated with an increased risk for cardiovascular events, possibly by decreasing PGI2 production mediated by COX-2 as discussed above. Non-selective Nsaids can block aspirin binding to cyclooxygenase when used concomitantly. Thus, patients who take aspirin for cardioprotection should avoid concomitant use of other Nsaids with aspirin if possible. Hemostasis. Thromboxane A2 enhances platelet aggregation, whereas PGI2 decreases it. Nsaids inhibit endothelial COX-1, thereby reducing thromboxane A2 production, and this reduces platelet aggregation, which is the first step in thrombus formation. Bleeding time is therefore prolonged. Inhibition of COX-1 is irreversible by aspirin and reversible by other Nsaids. As platelets lack nuclei, they cannot synthesize new COX enzymes if they are inhibited by aspirin. Therefore, thromboxane is not produced for the lifetime of the platelet, which is 3 to 7 days if aspirin is administered. This is why aspirin is often not administered for at least 1 week prior to surgery. Other Nsaids apart from aspirin are not utilized for their antiplatelet effects, but they can still prolong bleeding time. COX-2 specific inhibitors have no such antiplatelet effects and will not increase bleeding time. Effects on bone healing. Theoretically, prostaglandin inhibition by Nsaids may compromise bone healing following fractures, as the acute inflammatory response to bone trauma induces COX-2 in osteoblasts. However, current studies are not robust enough to preclude their use, although many orthopedic surgeons do prefer to avoid them to avoid compromised bone healing. Central nervous system adverse effects. Headache, tinnitus, and dizziness may occur. Hypersensitivity. Around 15% of patients taking aspirin experience hypersensitivity reactions such as urticaria, bronchoconstriction, and angioedema. Fatal anaphylaxis is rare. Patients who have experienced severe hypersensitivity to aspirin should avoid using Nsaids. Skin reactions. Idiosyncratic rashes can occur, especially with mefenamic acid, 10 to 15%, and sulindac, 5 to 10%. Skin reactions range from mild urticaria, photosensitivity reactions, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Mechanism is unclear. Rey syndrome. This is a rare disorder occurring in children characterized by acute non-inflammatory encephalopathy or hepatic encephalopathy, fatty degenerative liver failure. It typically occurs after a viral illness such as viral upper respiratory illness, viral gastroenteritis, and other viral illness with exanthem. Reye syndrome is associated with the use of aspirin during the viral illness. No other explanation for cerebral edema or hepatic abnormality is present. Epidemiology. Mortality has decreased from 50% to less than 20% as a result of early diagnosis, recognition of mild cases, and aggressive therapy. Since the withdrawal of aspirin for pediatric use, the incidence of Reye syndrome has reduced dramatically. Around 0.03 to 0.06 cases per 100,000 per year in certain countries. Pathogenesis. Mitochondrial dysfunction from mitochondrial injury results in disrupted oxidative phosphorylation and fatty acid beta oxidation in a virus-infected sensitized host. The host may have an underlying occult inborn error of fatty acid oxidation, urea cycle, or mitochondrial disorder. The host usually has been exposed to mitochondrial toxins, most commonly salicylates in more than 80% of cases. Hepatic mitochondrial dysfunction results in hyperammonemia. Hyperammonemia induces astrocyte edema, resulting in cerebral edema and raised intracranial pressure. Etiology includes viral pathogens, salicylates, inborn errors of metabolism, toxins, and other medications. Clinical features include vomiting, diarrhea, hyperventilation, encephalopathy, hepatomegaly, dehydration from GI losses, and multiple complications such as status epilepticus, brain herniation, aspiration pneumonia, etc. Workup includes serum ammonia, liver function tests, LDH, blood glucose, electrolytes, urea and creatinine, coagulation studies, free fatty acids and amino acids, which may be elevated, arterial blood gas analysis, urinalysis, CSF analysis, CT or MRI brain, EEG and liver biopsy. Since no test is specific for Reye syndrome, the diagnosis must be one of exclusion, with the main differential diagnosis being inborn errors of metabolism. Treatment. No specific treatment exists for Reye syndrome. Follow ATLS guidelines for resuscitation and provide supportive care based on the stage of the syndrome. Salicylate toxicity. Pathophysiology of salicylate toxicity. Salicylates uncouple oxidative phosphorylation, leading to increased CO2 production, increased oxygen consumption, accelerated activity of the glycolytic and lipolytic pathways, depletion of hepatic glycogen, and hyperthermia. Salicylates inhibits amino acid synthesis and inhibits Krebs cycle enzymes. Toxicity is related to the dose, with mild toxicity occurring at 150 mg per kg, moderate toxicity at 250 mg per kg, and severe toxicity if more than 500 mg per kg is administered. Phases. Phase 1 lasts for up to 12 hours. There is primary respiratory alkalosis. Direct respiratory center stimulation by salicylates causes hyperventilation. Hyperventilation results in primary respiratory alkalosis that is compensated by increased renal bicarbonate excretion and resulting alkaluria. Hyperthermia occurs due to increased metabolic rate. In phase 2, this phase may begin within hours and may last 12 to 24 hours. Paradoxical aciduria occurs in the presence of continued respiratory alkalosis when significant amounts of potassium has been lost from the kidneys. During phase 3, uncompensated respiratory acidosis occurs as the respiratory center becomes depressed, leading to hypercapnia and respiratory acidosis. Plasma bicarbonate is depleted from renal excretion. Elevated and ion gap primary metabolic acidosis occurs from the accumulation of pyruvic, lactic, and acetoacetic acids produced from uncoupling of oxidative phosphorylation. Phosphoric and sulfuric acid accumulation produced from inhibition of the citric acid cycle, uncoupling of oxidative phosphorylation, and renal insufficiency exacerbates the metabolic acidosis. Ketone bodies from increased metabolism of fatty acids also contribute to the metabolic acidosis. Timing: it begins 4 to 6 hours after ingestion in a young infant and 24 hours or more after ingestion in an adolescent or adult. Other effects. Metabolic effects includes elevated anion gap primary metabolic acidosis as described above, dehydration from GI losses and insensible fluid losses, hypoglycemia from increased cellular metabolic activity due to uncoupling of oxidative phosphorylation, discordance between levels of plasma and CSF glucose, and symptoms of CNS hypoglycemia from intracellular glucose depletion occurs. Hypokalemia from renal losses, hypocalcemia from primary respiratory alkalosis, and hyperthermia. Neurological effects includes Rey syndrome and neurotoxicity from salicylates and results in neurological symptoms. SIADH may occur as well. Respiratory effects are described above. Non-cardiogenic pulmonary edema and acute lung injury can occur. The initial hyperventilation is followed by respiratory arrest. Aspiration pneumonitis can occur when the gag reflex is depressed. Cardiovascular effects includes tachycardia, hypotension, dysrhythmias, asystole, ECG abnormalities from hypokalemia, etc. Gastrointestinal effects includes hepatitis, GI bleeding from damage to the gastric mucosa by salicylates, nausea and vomiting from CNS toxicity or gastric mucosal damage, pylorospasm, decreased GI tract motility, and bezoar formation, which occurs with ingestion of many tablets, pancreatitis and intestinal perforation. Renal failure can occur. For musculoskeletal system, rhabdomyolysis can occur from dissipation of heat and energy resulting from oxidative phosphorylation uncoupling. Bleeding and DIVC can occur from hypoprothrombinemia, platelet dysfunction, and inhibition of vitamin K-dependent enzymes. Contact dermatitis and diaphoresis can occur. Clinical features. Mild form is characterized by nausea, vomiting, sweating, tinnitus, hyperventilation, headache, mental confusion, dizziness, tachycardia, and hyperactivity. The severe form is characterized by restlessness, delirium, hallucinations, lethargy, fever, convulsions, coma, respiratory and metabolic acidosis, dysrhythmias, bleeding, ARDS, multi-organ failure, and death from respiratory failure. Children are particularly prone to salicylate intoxication. As little as 10 grams of oral aspirin can cause death amongst children. Workup. Initial and serial salicylate levels is usually elevated by 4 to 6 hours post-ingestion. Therapeutic range for plasma salicylates is 10 to 30 mg per liter or 0.7 to 2.2 millimoles per liter. Plasma levels of salicylates of more than 40 mg per liter or 2.9 millimoles per liter are considered toxic. Urea and creatinine, electrolytes, arterial blood gas, combination of a respiratory alkalosis and metabolic lactic acidosis is the hallmark of salicylate intoxication. Decrease in PaCO2 and decreased bicarbonate occurs with initial normal arterial pH, which reduces as lactic acidosis progresses. Urinalysis, chest radiograph, serum glucose, serum paracetamol levels, liver function test, coagulation profile, full blood count, ECG, and to identify salicylate bezoars, ultrasound, CT abdomen, and endoscopy. Management. No specific antidote is available for salicylate toxicity. Stabilizing the airway, breathing, and circulation as per ATLS protocol, such as endotracheal intubation and ventilatory support in respiratory failure. Kindly refer to the video on organophosphate poisoning for a brief discussion on general measures in managing cases of suspected poisoning. Limit absorption by gastric lavage and activated charcoal, 1 gram per kg divided into 3 doses 2 hours apart if it can be started within 2 to 3 hours of salicylate ingestion. Enhance elimination by urinary alkalization and hemodialysis. Urinary alkalization is the cornerstone of treating salicylate intoxication. Alkaline urine promotes the dissociation of salicylic acid. Salicylic acid becomes trapped in the renal tubules where it can be excreted in the urine. An example of a protocol is bicarbonate loading dose of 1 to 2 MEq per kg, followed by an infusion of a bicarbonate solution created by adding 3 ampoules of sodium bicarbonate to 1 liter of dextrose 5% and run at 2 to 3 ml per kg per hour, or 1.5 liters of 1.26% sodium bicarbonate in dextrose 5% IV over 3 hours. Aim for urinary pH of 7.5 to 8 and a urine output of 1 to 2 ml per kg per hour. Potassium should be added to the bicarbonate solution to produce 40 MEq per liter, as bicarbonate infusions promote hypokalemia. Hypokalemia hampers the ability to alkalinize the urine, as hypokalemia promotes the secretion of hydrogen ions instead of potassium by the distal tubules. Hemodialysis is the most effective method of clearing salicylates from the body. Indications includes serum salicylate level of more than 100 mg per liter, renal failure, ARDS, and progressive illness despite alkali therapy. Correct metabolic abnormalities such as hypoglycemia and hypokalemia, correct dehydration, and provide supportive care. Drug interactions. Most Nsaids are highly protein-bound, 90 to 99%. The unbound fraction is active. Nsaids can potentiate the effects of other highly protein-bound drugs or substances by displacing them from protein-binding sites. Examples of these drugs include oral anticoagulants, oral hypoglycemics, sulfonamides, anticonvulsants, bilirubin, thyroxine, and triiodothyronine. Salicylates can also be displaced from their protein-binding sites by other highly protein-bound drugs, resulting in increased concentration of free salicylate. The secretion of salicylate in the urine can affect uric acid excretion. Low-dose aspirin of less than 2 grams per day results in decreased uric acid secretion, thus aspirin should be avoided in patients with gout. For high-dose aspirin of more than 4 grams per day, uric acid secretion may be unchanged or increased. Aspirin also antagonizes the effects of some antihypertensive agents and some uricosuric agents such as probenecid and sulfenpyrazone. Pregnancy. Most Nsaids are pregnancy risk category C during the first 2 trimesters. Paracetamol is preferred if analgesic or antipyretic effects are needed during pregnancy. Paracetamol is pregnancy category A. Nsaids should be generally avoided during the 3rd trimester due to the risk of Nsaid-induced premature closure of the ductus arteriosus via inhibition of PGE1 synthesis. This is a list of FDA pregnancy categories A, B, C, X, and D. These are my references. Thank you.